Hello. First of all, I'd just like to thank the panel and its organizers for allowing me to be part of it, and for you all for your continued attention throughout this event. Thank you. So I have nothing to disclose. Again, as Dr. Cripps just said, the operations often are in some ways the simple part, and sort of the mysterious box is what happens in the post-operative period, and sometimes in spite of everything that you can do, it's a little bit nebulous as to how things are going to show up. The way that I organize this talk, first I'm going to talk about kind of the initial acute management, sort of the calls and concerns that you're going to have right in the first, like post-op day 0 to 1. Then I'm going to talk a little bit about basically how we set the table for the body kind of to try to do its best work in spite of a situation where sometimes the odds are a little bit stacked. And then finally, we'll talk about some of the high-risk issues, outcomes and complications, which in this area are to some degree inevitable. First of all, I just want to start with about the patient being intubated. So if your situation is a lot like ours, generally speaking, if you get that consult from an already admitted patient coming from the MICU, they tend to go to the operating room intubated to start with, and usually if that's the case, your anesthesiologist doesn't necessarily have a plan to extubate that patient post-op. So that's one of the things that you have to know. Then the way that you approach sort of what you're going to do with that, we like to get our patients extubated as soon as we can, but we like to have a little bit of context when we make that decision. There's a few things that you need to do. You need to consider the pros and the cons. If your patient is really sick and has some renal failure, you can sometimes get a little bit of benefit from your ventilatory situation in that you can kind of work with the acid base just a little bit. It gives you a small amount of wiggle room. Additionally, it gives you some compliance information in case you end up with the patient that comes out with a little bit of oliguria, hypotension, sort of can tell you, help with your differential. And again, this is important. It's critical to talk to the anesthesiologist during the case. You can have a patient who, when you close, all the peak pressures are really nice, but it's because they were on pressors and they've been run dry intraoperatively. Then you get them back and you want to get them off the pressors, and you end up tanking them up, and then all of a sudden they have low urine output and they're not ventilating very well, and it's because they've got a compartment syndrome. So you kind of need to know that sort of context going in. And so I tend to use it if I know that I'm going to have to actively resuscitate with volume. I tend to keep the patient intubated, but we try to get them extubated as soon as possible. So the key is anticipation again. You need to understand what your needs are for resuscitation, whether they be if you're going to have high and sensible losses. Was the case long? Was it open? Was there a lot of contamination where you're going to see a lot of third spacing? You also need to consider the condition of your patient. Is this somebody who's going to basically tire out because they have very little reserve, they're frail to start with, they're deconditioned? And then generally, if I'm worried at all about acid base because I have a pretty sick patient with liver or kidney disease, then we tend to go proceed with caution. The most common call that we get actually after cases like this overnight, if there's a problem, is going to be that the nurse tells us that the urine output's low and they're a little bit low on their blood pressure. Oftentimes, particularly at the beginning of the year, I work at an academic center, and the response of the resident is to give a quick bolus, and then they give another bolus, and then they give another bolus, and another bolus. And it's because there's this common pitfall of giving boluses without considering your differential diagnosis. So you need to know basically, is this a situation where the patient is bleeding? Are they becoming septic? Or are they developing a compartment syndrome? Those are probably, I'd say, top three. Every now and then we have a really sick patient and we figure something out having to do with endocrine, like steroids, but it's usually those top three. And so context is important. You want to know basically what the case duration was like, EBL. Was there a lot of spillage? What kind of resuscitation did they do intraoperatively, or did they run them with a lot of pressors? That's critical. And then the acuity, and was there any delay in getting to the operating room? Sometimes you can anticipate that they have a higher demand for fluid resuscitation postoperatively. It's important to go take a look at the patient if you can. You need to see basically what the hemodynamics look like. You need to press on the belly and see how taut it is. You need to basically flush the Foley, make sure you're not having a problem there. And one thing that I like to do is actually, and if it's available, we like to take one of those bedside ultrasounds, and we like to look and see basically how compressible the inferior vena cava is. It gives us an idea if our patient's dry or if they're full. It helps us distinguish between like a compartment syndrome situation or somebody that could use more fluid. So the open abdomen has been covered quite a bit, and a lot of the work has actually been done by the panel, which thank you for all of that. Well, again, I think we like to try to close as safely as we can as soon as possible. One thing that we will see as being an issue is that people in their haste to try to close the abdomen will sometimes try to dry the patient out a little bit prematurely, just because patients will end up with a fair amount of edema in the bowel, and they'll be, hard to close. But you have to be wary if you're going to do that too aggressively, because the fluid shift basically from the extravascular space to the intravascular space sometimes is a little bit slower than what you can get out of the blood with your diuretic. So you can end up basically hurting your tissue perfusion, and you'll see your creatinine rise and your anastomosis not doing very well if you're too aggressive on that and do it too early. So when I think of basically more of the long-term management, the way I think about setting the table for success is I try to have ideal tissue perfusion, source control, and nutrition. And basically I break it down kind of like that. That's just how I think about it. So we'll start with tissue perfusion. And tissue perfusion is just all about appropriate anticipation and understanding sort of the natural history of fluid shifting. It's important to know early on sort of what kind of insensible losses you're going to have. Is the patient febrile constantly? Was there a lot of gross spillage? Were they septic before they went intra-op? And basically you need to fill that tank as soon as you can. Sometimes it can become complicated, and many of our older patients with CHF, I think those are some of the more challenging patients because there's a fine line that you're trying to walk where you want to fill the tank but not overfill it, and you need some adjunctive strategies for that. Other devices like Vigileos, for example, can be helpful in that setting. Sort of a few days out, if you've had adequate source control, you're going to start to see fluid shift back in. And this is pretty helpful, but it's also actually a tricky time because in those patients that actually have some sort of heart issues, this is when the dysrhythmias actually start to show up. So it's sort of like a pro and a con. It's pro because you think, oh, well, maybe the infectious issues are sort of resolving, but you have to basically stay ahead of what the fluid status is, and that's going to be kind of your indicator. The main thing is, though, fix your volume first. Your pressors are not going to improve your mesenteric microcirculatory perfusion, and in fact, they could hurt you by diverting the flow. So remember that those pressures are a surrogate for perfusion, and perfusion is what's most important. So basically, fill the tank first. Next, the antibiotics. So Dr. Ye actually mentioned the Stop It trial earlier. So this was a multi-center open-label study with 518 patients. This study assumed that, or it started with the assumption that you had an adequate source control infection or procedure after an intra-abdominal infection. And what it compared was patients were randomized to either a fixed duration antibiotic therapy, which was 4 plus or minus 1 day, averaged to be 4, or they had to get continued antibiotic therapy until 2 days after symptom resolution. Symptom resolution meant that they had to be free of fever, actually less than 38. It was pretty tight in this study. They had to have a normal white count less than 11. They had to be able to tolerate at least half of their feeding. And so that was basically the criteria for that. And when they did that, that ended up working out to be approximately 8 days on average that it took to get resolution. When they compared the two groups, there was no significant difference in outcomes. The scary part of implementing this particular tool, though, is that about 20% in each group, just a little bit over 20%, ended up either with a superficial surgical site infection, a deep infection, or death. Now, the death was like maybe 1 or 2 patients, but still, like when you have that patient, you're always asking yourself, do I have source control? When you see that, video 2 that our colleague just presented, you're always going to wonder, basically, did I get everything, and how do we define source control? And I think that is sort of what keeps you up at night. I don't have anything better for you there. I just say that's basically going to keep you up at night. You're always going to wonder. But as Dr. Ye also pointed out, in that situation, no matter what you do, it's probably not going to matter. And so eventually, usually what happens is you go back and you re-image after about a week, and you find fluid pockets that you can control in other ways.
Who's the antibiotic police in your institution? Is that the attendings, or is it the pharmacologist? Pharmacy? Who's the antibiotic police?
For us, we actually have a council that's run by Dr. Christine Kokenauer, who oversees that, but it's sort of a multidisciplinary group that incorporates ICU attendings as well as the pharmacy and infectious disease.
Less is better happens in that.
Correct.
I bet you, though, how many people here in the audience have now Epic or other overlays put in by your antibiotic steward people over all of this? Yeah, it's increasingly getting, and you can't get agents.
There are actually in our institution, there's a stewardship rounds. There's a couple of guys from infectious disease that round. I'm not sure what authority that they have, but they do have suggestions.
They tell the pharmacy not to give you the drugs.
You know,
But they have to have the hammer. They don't have the hammer, Dr. Brown? There's no hammer?
I got the hammer.
For those of you who have access to this lab test, we've started using procalcitonin in order to help us guide and support your decision to stop antibiotics. It took about 3 years for our hospital to get it so that it would come back within hours as opposed to days. So that is one biomarker that can support your decision to stop it early.
And we've actually begun incorporating procalcitonin this year, but it's just not widely accepted yet. We have the lab, and I think that they're trying to get buy-in from.
In Europe, it's used all over the place, but in the States, I think it's mostly not accepted because of the logistics of getting it back in time to actually make a difference.
Yeah.
Because I also think with this trial, the Stop It trial showed that you don't change infections. You're actually, by doing your antibiotics more, delaying the time that you found your abscess. So they're still coming, but there was the days. There's like a 5 day. So you actually, that was the thing that I really took away from this. More sounds better to us, right? They're sick. You got that poop in there. You know, the antibiotics. I think we're treating ourselves feeling better, but that data was very convincing that you're not changing the outcome, you're just delaying finding the problem.
Right, there's a nidus there that you just can't get with antibiotics, and so I agree that the presentation just ends up being delayed, and you end up with the resistance issue still is also an issue. So. Nutrition actually, for me, is one of the more exciting areas here because I think this is an area where we potentially, over the next couple of years, have potential for breakthrough, for example. Currently, most of our feeding guidelines are based primarily on expert panels, people coming up here and telling you things, but not having a lot of numbers behind it, as I intend to do today. But so there's currently a lot of there's just a lack of well-designed real trials that compare the two, and now I think that there tends to be bias in the field too. So design of trials and putting people in one group versus the other has become problematic for study design. That being said, if you look at a lot of animal studies, for example, and to some degree in some of the clinical trials, what we do know is that parenteral nutrition has some adverse effects, including hepatocellular injury and immunosuppression through a couple different described mechanisms. And so it's thought that at least the pendulum has swung in the direction of enteral nutrition now for basically preservation of the gut, feeding the gut, nutrition of the gut, health of the gut, as well as that lack of immunosuppression and infections that we see. There are many studies that are pretty large. I won't go through all of them, but basically the takeaway points are that when compared sort of against each other, parenteral nutrition versus enteral nutrition, what is generally seen with enteral nutrition is that there tend to be fewer infections, there tend to be fewer pneumonias, abscesses, they stay on the vent for a shorter time, and there is a cost benefit as well in many studies as well. It's important when you interpret this data to understand if the populations that are getting one type of feeding versus the other are the same, because many times sort of the best they can do is they sort of just take what they get retrospectively, and sometimes it's just not an equivalent group. The last study I will highlight, though, the Caesar et al., they actually started everybody on enteral nutrition, and then the ones that couldn't tolerate the enteral feeding were given either no additional help, or they were basically supplemented with parenteral nutrition to keep the calorie count high, to just sort of optimize that. And when they did that, basically, the patients that actually got the supplementation for the extra calorie benefit had a higher infection rate. They stayed on the vent longer, and they had more cholestasis. They also ended up getting dialyzed longer. So basically, the extra calories didn't help. And I think that we're coming to understand that the way that the body utilizes nutrition in the setting of inflammation is not the way that we do in a typical setting. And sort of the original thought that, like, oh, we're going to throw some calories at it and some vitamins and minerals at it, that's just not enough, basically, to get the body to change its metabolism the way that it's actually going to use things. Sort of to speak to that was a study recently done, actually around here, by Dr. O'Keefe. They wanted to do a metabolomic analysis of what happened when you took patients that were critically ill from a trauma center, and they either got enteral nutrition versus parenteral nutrition. Generally, what they found was even when the calories were the same, the utilization was completely different. So both patient groups ended up with elevated levels of amino acids in their system, but only the enteral nutrition group was actually able to really effectively use that to upregulate its urea cycle, to make sure that the antioxidant usage was restored and increased ribonucleic acid synthesis. The parenteral nutrition had all the calories in the world, but it was like sort of starving amidst wealth, like they couldn't use it. So these are the kind of studies that I think are going to sort of open our eyes to how we address nutrition in the future, and hopefully we're going to ultimately improve our outcomes as we get to understand this a little bit better. Last 2.5 minutes, just a little bit about high risk and outcomes. Basically, you sort of will know it when you see it. Patients that ended up or started on prolonged pressor use or still are requiring it, you're going to basically have anastomotic leaks, essentially. Ascites. Basically, those patients tend to have fluid shifts. They're hard to keep resuscitated optimally. And if you patch them with anything like some fat, it just kind of doesn't stick very well. It's kind of been our problem. The patches just don't work. Malnutrition. So we all know if the patients come in and they are like super sick, you know, they're going to have that acute phase reaction. They're going to drop their albumin anyway. But the patient's nutrition, again, is just it's one of those issues that we haven't been able to completely overcome despite all of our attempts, and we're going to figure out something better in the future than just throwing more calories at it. I should have put in malignancy, but malignancy is pretty high risk. Steroid use, radiation, immunosuppression was touched on earlier. Avastin, so any anti-angiogenic factors, if they've been used within a month, they tend to basically hurt your healing. And then one thing that we've actually seen recently is that in our patients, we have a large patient population that has chronic methamphetamine abuse. And for some reason, those patients often tend to come out great initially, and then about 4 or 5 days later, they begin to collapse. And then when we look at them, they have a very diffuse non-occlusive mesenteric ischemia. Basically, everything's dead. We're still working on that. Figure that out. Yeah, but so meth.
You have to mention the
Do you know the
cocaine
mechanism
groups
of it?
also.
Because I think we're all seeing it.
Yeah.
And in cocaine,
So-
I think we knew the mechanism better, right? What is the mechanism? Your best guess.
Yeah, exactly. It would be a guess at this point. So there's actually a mouse model where they.
They give mice methamphetamine?
Yeah, they do. So I thought this was going to be completely difficult because how are you going to give a mouse 20 years worth of methamphetamine? But
Ow.
if you give it a mouse just 10 days of methamphetamine, they actually end up being more susceptible to a cardiac injury from ischemia. And it's more prevalent in the females than the males, which is basically what we see in our people. What I actually think it has to do with is sort of like smaller vessel occlusion due to like a depletion or inability of the adrenergic response is what I would sort of guess. Either I just think that the receptors don't work as well.
So yeah,
That's what I speculate on.
I thought it's related to the acidosis that methamphetamine and both cocaine induced. They both have elevated metabolic acidosis, which would increase base deficit clinically, and there's all kinds of speculation about what the actual mechanism is.
I think so we see it after a few days, and they're not actively using when we see it, and so I don't.
That you know about.
Well, no, but I mean, a lot of times they're intubated, so like, yeah.
That never stops those patients' friends who come in and
Right.
they want to sneak them a hit on the side.
I actually think, I agree. I think that there's probably an initial hit, but I also think that there's sort of an adrenergic failure, actually, that we're going to see. And I think that we just have to look at sort of the small vessel. But we've seen this where, like, we can find the larger vessels feeding it, and they're just wide open, wide patent, and then everything else is dead in spite of that. So.
And as opioids are becoming more expensive out in the shadow world, methamphetamine use now is skyrocketing because it's cheaper.
Yeah.
And so we're seeing our methamphetamine problems are uprising yet again, and it's a devastating one.
Yeah, devastating for sure. So I'm actually over time, so I'm going to blast through the risk
It's
thing.
okay, we're good.
You're
We're
correct.
good.
We'll give you a little extra time because I know you need it.
I just need a little bit of time. That's what we need.
You have to subtract the Andre Sherry time.
All right, so what I will say basically about outcomes is the following. So this is actually a study that came out of Korea where they looked at 117 different intestinal perforation cases. Intestinal perforations tend to have a fairly high complication rate in general. But the point that I wanted to bring up was just the results. So they found a 60% post-op complication rate. I think generally speaking, no matter what your etiology is of your perforations, your complication rate tends to be, it's variable to some degree based on sort of what it came from, but it's usually going to be somewhere between this 20 and 60%. And so all you can do is the best you can do to some extent, and just sort of optimize as best we can. The factors that they did see sort of show up in many of the different scoring mechanisms that people use to predict outcomes. So low systolic and diastolic blood pressure initially pre-op, for example, low serum albumin, protein, cholesterol, high blood urea, nitrogen, and feculent ascites. Or what they found. And when they did their multivariate analysis, the low systolic and pressure and the feculent ascites actually ended up sort of having a direct correlation with mortality, as you might expect. There's many different types of scoring systems. Dr. Ye mentioned one earlier, which I apologize for not including. He's going to get me on that one later. But basically, my point with all the scoring systems is that sort of they all kind of include the same usual suspects. Old age, systolic blood pressure, sort of the blood loss during the case, if they have additional comorbidities such as cardiac or respiratory failure issues, the level of contamination, if there was any delay in presentation, presence of malignancy. So those tend to basically continue to show up. The surgical APGAR score is another one where they looked at about like 69 different variables and they boiled it down to 3, sort of what was the estimated blood loss during the case, what was the lowest mean arterial pressure and what was the lowest heart rate. And then based on that, they score. And the higher the score, the better it looks out. But patients with about 6 or less tend to find themselves in the ICU. In general, patients with a 4 or less, you can basically count on a major complication. NISQIP has a scoring calculator as well, which is developed on several million cases in many different hospitals that do things differently. So it gives you a pretty broad stroke as to prediction because it's got a really wide sample. But basically, again, a lot of the same players that show up. Was there sepsis pre-op? Was there sort of ascites? Does the patient have malignancy or diabetes or CHF? A lot of the same usual players basically continue to show up. These calculators are helpful when you're talking to families or when you're talking to the patients about sort of how to go, and so they can be useful. They're usually pretty easily found on the internet. But it is important basically to have that discussion because you'll get people through the operation, but it's more than an operation that you're consenting them for. You're sort of consenting them for a pathway, and the pathway can be a little bit treacherous. Oh, wrong button. So in summary, the initial operation, I shouldn't say it's not too technically, it can be technically challenging, but the postoperative course is pretty rough often. But you have to anticipate things. You have to anticipate the needs, the shifts. I would strongly emphasize communication with your anesthesiologist during the case because it's going to dictate in large part sort of what's going to happen initially when you set your table. And then basically my 3 pillars, perfusion, source control, and nutrition. Hopefully we'll get better and better with the nutrition. Stop it. So basically it's all about source control and antibiotic stewardship, and then understanding what you have to do when the stewardship fails is usually reobtain source control at some point. Feed the gut when you can and anticipate the complications to stay ahead of the game. Thank you very much.